Welcome to Doc Talk, your go-to podcast for exploring the dynamic field of clinical emergency medicine. Each episode, we delve into real case scenarios that challenge and inspire medical providers just like you. From mastering point-of-care ultrasound to excelling in airway management and ultrasound-guided regional anesthesia. Our discussions aim not only to inform, but also transform your clinical practice. But there's more. We invite you to take your learning further with our hands-on educational courses, designed to equip you with the confidence and skills necessary to handle any emergency situation. Join us on this exciting journey of professional growth. Your next significant clinical breakthrough begins right here.
So shut up, sit down, start listening. This will change your life.
Thanks for joining us again for another monthly case review. We're going to open up the emergency department scrapbook and go down memory lane and pick out another case. So here we go. Another kidney stone. So what, these guys are miserable. Quite uncomfortable.
That guy looks on the older side though, so he could have problems other than a kidney stone.
No, he literally told you,
Yeah, I know.
I have another kidney stone.
I've been told that before by a guy that was just dead about 15 minutes later.
So you
sometimes they're lying.
You can't even get him on a gurney.
Yeah.
He's so uncomfortable. All right. So abrupt onset of right flank pain. Feels like my kidney stone. So B, 72-year-old, history of hypertension, diabetes, and smoking. Right?
Mm-hmm.
And he's wild. Like, wild. So he says it's a kidney stone. History of. Definitely could be.
Definitely.
And then, obviously, other
You
things.
gotta think about more serious problems.
Mm-hmm. So what's your approach here? What's your go-to? What's your first thing you want to do after you get this guy laid down?
I'd give him medications to slow him down so that he can cooperate with the second thing I'm going to do, and that's going to be an ultrasound exam while I talk to him.
Okay.
And I
All
can
right.
tell you exactly
So
what windows
where
I'd
are
look
you
at.
going to look first?
I would look at the ipsilateral side that he's complaining of pain, and whether he has dilation of the collecting system or not, I would look at his aorta next.
Yeah. So that's great. He can't lay down. They don't have an IV in yet. So you scan him, standing upright with him moving all over while the nurse is trying to get an IV in. Give him an MKO melt just to get something going.
He's right. He's a perfect person to have an aneurysm.
Yeah.
He's like the right age. He smokes.
But you're an academic. You work at a big place. I mean,
Yeah, I've worked a
believe
lot
what
of places,
I-
and actually one of them where I watched a guy like this for a couple hours because I didn't think of it, ended up dying from a ruptured aneurysm.
so
It was just me and him in the ultrasound machine in the apartment. So
I just
I've
want to say
also
one
learned
thing.
by-
You want to do this ultrasound in the stage that you're currently describing him as. If you can't lie him down. In other words, don't sit back and let the nurses try to control him with pain meds, and you're a half hour, 45 minutes into it before he finally slows down. Just go in while he's writhing, standing up, and get under his shirt and do these exams.
Yeah, and usually what will happen is at some point in your career, you'll have someone show up like this, and then they'll die in front of you. Mm-hmm. And afterwards,
And smart people don't have to have that happen themselves. They listen to other people that say it happened.
And so
but some people have to experience everything themselves.
You've had that happen, and everything after that is futile. Mm-hmm. It's high on your radar. You're quite concerned about it, and you don't screw around anymore.
The other thing to think about is this guy is people who are in shock are often agitated. So, he might just have a kidney stone, but he also might be just underperfusing his brain and freaking out. Yeah. And that happens to people who have bad things like bleeding.
So here we go.
One last point I just want to make. There's a landmark study from many, many years ago, I'd say decades ago now, that 10% of people who were referred to CT for evaluation of obstructive uropathy, 10% had AAAs. So this is not a rare condition.
Yeah, since the screening started, there's less of this, I would say, but it's still, they walk in like this.
Yeah.
So I would say a blood pressure of 102/64 looks normal on the surface, but I would like to know his norm. If he's really writhing in severe pain, it should be a lot higher than that. And for a guy who's 72 with a history of hypertension, that's a low blood pressure.
Beta blockers?
Maybe, but they're doing a good job.
And maybe that his bleeding has tamponaded and it still hurts because it's under pressure and there's a retroperitoneum. That could be too.
So
Let's move
you
forward.
wanted to see that. I mean, I wanted to see that. I see hydro. I'm not sure that hydro alone will make me not be concerned. But the other thing that you don't see is you don't see free fluid in the right upper quadrant. Right? So that, I mean, that's good there. And you don't see hydronephrosis.
Yeah.
Well,
what you can get.
the absence of free fluid rules out the rarer 10% of intra-abdominal ruptures. It doesn't rule out the 90% of retroperitoneal ruptures.
Yeah, so most AAAs that ruptured don't have fluid in their belly
Yeah.
that you can see.
So there you have it.
Yeah, and this is where you want to be just like a pro at pattern matching. You might not even be able to fully describe that well, but you better recognize that as grossly abnormal and contributory.
And as soon as you see this, you don't have. Some people confuse this and they're looking for bleeding. That's the point is this guy has symptoms of a ruptured AAA, and now you found a AAA. You have to assume that this is bleeding, and
Yeah, and to say that,
and he doesn't have long to live. I would say that.
so I would just want to addendamize that. You have to assume it's a AAA because you can't demonstrate it's a AAA that's ruptured. The bleeding does not show up in the retroperitoneal space. So this is a clinical correlation that's really important.
Yeah. And just identifying that you have essentially, you're going to be measuring all the way from up here
Yeah.
through here down to there.
That anterior thing is all thrombus. Thrombus tends to end up anteriorly and laterally, sometimes posteriorly, but usually anterior and lateral.
Yeah. And you get the second view. Diagnosed in seconds.
So these are not they're never hard to find because the average one that ruptures is 7.5 centimeters, and that's big.
That's our average, and then our largest is 14. That's a basketball. And the other thing I'll point out here is they're easy to diagnose because as they expand, they can't go anywhere but anterior. They can't go posterior because that's a vertebral column, and it displaces bowel gas right and left for you.
So
So
the
if
bigger it is, the easier it is to see.
And the corollary is kind of true that if you struggle and struggle and struggle and can't see it, it's unlikely to be there at all.
Well, the key is if you can't see the aorta, just press harder
So
because you can press the bowel out of the way.
So your next call is to your air care friends. And you call them and the wife's like, you're calling the helicopter for a kidney stone?
And I would
the
just
bad
give
one.
some blood. Because if you're wrong about it bleeding, who cares?
Yeah.
If you're wrong and you don't give blood, the guy might be dead when he gets to the.
yeah, you're not wrong about the bleeding though.
So, I feel that the only thing you have to do here is you need to get them out and resuscitate them.
Yeah.
Their CT is going to add nothing to what you're going to do at a small place. Again, as far as I'm concerned, you can do whatever you do after they get there alive. I don't care if you guys do repeat all whatever, but I want to get them there and get them gone.
And I've seen people get confused between this and a dissection and tell you to, why don't you start some esmolol and get his pressure down? And I'm like, no, he's bleeding.
Yeah.
Don't give esmolol to people who are bleeding.
Yeah.
For a dissection, it makes sense, so you don't dissect further, because that's not a bleeding problem. But a ruptured aneurysm is a totally different thing. It's a bleeding problem. It'd be like giving esmolol to a trauma patient who's bleeding. So you got to be careful to not take that advice.
Point out one other thing is a quarter of the people who are in that condition from a ruptured AAA, a quarter of them have active myocardial ischemia as well. So you just tilt that probe 30 degrees up toward his chest and start taking a look at his chest and do some other diagnostic stuff, troponin and EKG, stuff like that.
Yeah. And the reason is because it's the same. What causes a AAA and coronary disease is the same process, atherosclerosis, and so you're pretty much 100% of them will have bad coronary disease. And when they drop their pressure, even if it's a relative drop like this guy's, they'll start having coronary ischemia. Some of them will come in with chest pain, and they'll have coronary ischemia. That's a symptom they're having, but the reason they're having it is because they ruptured their AAA. And so I've had patients like that too that came in with crushing chest pain. hypotension. You think, all you're thinking is heart because they're complaining of chest pain. Maybe they had syncope too. And you don't think of AAA right away, but you should. Go down and look at it. The two happen together pretty often.
Now, this guy's a sick guy, but I just want to make the point that in emergency medicine, we're at a very keen spot to do surveillance screening for these people who you have no suspicion thereof. Because to have found this 2 years ago on a routine visit would have been a real service for this guy.
Yeah.
Yeah, and I think especially when you're learning and you're trying to do normals and you're scanning people
Absolutely.
who have coughs and colds and waiting for other imaging in the department,
Right.
that is the time, and I'm much more passionate about screening than I ever have been, mainly because you end up on the wrong side of the ball when this happens. You're caught in the corner. They're something that could have been diagnosed in the bedside. Handheld ultrasounds people spend more money on coffee than what the probes cost. The imaging is getting better and better. It's a quick exam. I mean,
And if you find it ahead of time, the mortality once it ruptures is pretty high. And if you find it and they can have elective surgery, mortality is almost zero. So you really save somebody's life just by doing surveillance.
Yeah. Simple exam.
So anybody who's above 50 that's ever smoked in their life, right, I would say anybody above 50.
Does that include weed?
Weed, yes.
Okay.
But it's a quick exam. You come subxiphoid, image through the liver, find the aorta, and you can do a transfer scan of the abdominal aorta if you were slow, 30 seconds.
That's right. If you're slow, that's exactly
And
right.
again, if you can't see it, I'm not saying they don't have one, but
Probably
it's
don't.
probably not huge.
That's right.
Right?
And
So,
if you press hard, you can almost always see
Yeah.
99.9% of
So-
the
Yeah.
aortas.
Just explain to the patient what you're going to do. Tell them it's
Yeah.
going to last 10 seconds, and they'll take enormous pressure.
so
Yeah.
foundational exam, again, that right upper quadrant view, just go where you'd go for a right upper quadrant fast exam, right? And then to come up to get the aorta, just right down the middle.
Very good.
Subcostal. So it got to where he needed to go, got it repaired, lived, and it was a good save. We didn't waste a bunch of time. A few hours in someone like this can be the difference between
Yeah.
life and death.
Oh, 1
Half
hour.
hour can be.
Yeah.
So,
Very good.
all right. Thanks for joining us. We'll see you next month.